Today we are going to talk about asthma, its definition and the management of both chronic and acute asthma, and the various medications involved in treating the symptoms associated with asthma. Asthma is a chronic respiratory condition, as it affects the airways in the lung. In asthmatic patients, their airways are more sensitive to certain triggers such as pollen, which causes inflammation of the inner lining of the airways and bronchospasms. This results in a restriction of oxygen airflow towards the lungs and the patient experiencing the following symptoms of a cough, chest tightness and wheezing. Asthma is not curable, but the bronchospasms and inflammation of the airways are reversible, thereby relieving the symptoms of wheezing, breathlessness and coughing. Complete asthma control is defined as no daytime symptoms, no nighttime symptoms that wake the patient up at night, no asthma attacks, normal lung function, no need for rescue medications and no limitations when carrying out physical activities such as exercise. Severe acute attacks of asthma can have an adverse effect on pregnancy and should be treated promptly in hospital with conventional therapy, therefore women with asthma should be treated as normal and closely monitored during pregnancy. Weight loss in overweight patients, smoking cessation, breathing exercises are all lifestyle changes that can aid the management of chronic asthma. Exercise-induced asthma usually indicates poorly controlled asthma, and that treatment may need stepping up. To avoid unwanted side effects and unnecessary costs, treatment is gradually stepped down every 3 months, 25 to 50% each time, once control is achieved. Patients should be maintained at the lowest possible dose of inhaled corticosteroids. The BTS and SIGN guidelines should be followed in the treatment of asthma in both adults and children. Patients must undergo an evaluation whenever an update in their treatment regime is considered. An evaluation would consist of assessing their symptoms, measuring their lung function, checking their inhaler technique and adherence. The initial treatment of mild intermittent asthma in patients under the age of 5 includes the introduction of inhaled short-acting beta-2 agonists such as sal-butamol or terbutaline. If the patient is using their inhaled short-acting beta-2 agonists more than 3 times in a week, regular prevention therapy should be considered. These include the addition of either a low pediatric dose of inhaled corticosteroids or a leukotriene receptor antagonist in patients under the age of 5. If asthma control is still not achieved, initial add-on therapy should be considered. These include the following combinations of a low pediatric dose of inhaled corticosteroids and either a long-acting beta-2 agonist or leukotriene receptor antagonist in patients aged over 5 and just a leukotriene receptor antagonist in those aged below 5. If asthma control is still not achieved, then either the patient's dose of inhaled corticosteroids requires increasing to a low dose instead of a low pediatric dose. Steroid cards should be issued for high doses, especially in children where high doses are associated with side effects, including growth failure, reduced bone mineral density, and adrenal suppression. Monitor eyes for cataracts, and weight and height for growth. Persistent poor control requires a referral to a respiratory pediatrician. The initial treatment of mild intermittent asthma in adults and patients aged over 5 involve the introduction of inhaled short-acting beta-2 agonists such as sal-butamol or terbutaline. If the patient is using their inhaled short-acting beta-2 agonist more than 3 times in a week, regular prevention therapy should be considered. These include the addition of either an inhaled corticosteroid, leukotriene receptor antagonist, LRTA, or theophylline in children that are not able to take inhaled corticosteroids. If asthma control is still not achieved, initial add-on therapy should be considered. These include the addition of a regular inhaled long-acting beta-2 agonist, LABA, such as formoterol or salmeterol. If the patient shows no response to the LABA, it should be stopped and the dose of inhaled corticosteroid increased. If the patient's asthma continues to show no improvement, the following medications should be introduced into their treatment regime. A leukotriene receptor antagonists, modified-release theophylline or a modified-release formulation of a beta-2 agonists. If asthma control is still not achieved, then the patient should be started on a course of oral corticosteroids and referred to specialist care. Asthma can be categorized into either moderate acute asthma, severe acute asthma and life-threatening acute asthma. Moderate acute asthma is diagnosed when a patient experiences an increase in their symptoms and has a peak flow reading greater than 50 to 75%. Severe acute asthma is diagnosed when a moderate acute asthma patient develops one of the following symptoms: a peak flow reading between 33 to 50%, a respiratory rate greater than 25 breaths per minute, a heart rate greater than 110 beats per minute, and the inability to complete sentences in one breath. Life-threatening acute asthma is diagnosed when a severe acute asthma patient develops the following symptoms of a peak flow reading less than 33%, an arterial oxygen saturation reading less than 92%, and partial arterial pressure of oxygen reading less than 8 kPa, arrhythmia, exhaustion and hypotension. Near-fatal acute asthma is diagnosed when the patient requires mechanical ventilation. Acute asthma is initially treated with high-flow oxygen, 40 to 60%, to maintain O2 levels between 94 to 98%. Followed by a beta-2 agonist administered by an oxygen-driven nebulizer to avoid pulmonary oxygen displacement. A course of oral prednisolone for at least 5 days or until recovery. If the patient's symptoms do not improve, either of the following medications should be administered: nebulized ipratropium bromide, an intravenous dose of magnesium sulfate, or intravenous aminophylline. That is today's lecture on asthma. Thank you for watching. If you enjoyed the video, please hit the like button and subscribe.